Welcome to Spine Guy. I'm Dr. Brian Seal, a fellowship trained spine surgeon. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. In our last video, we talked about very cool technology, spinal cord stimulation. We talked about what it is, who's a good candidate for it. Today, we're going to talk about all the questions patients have surrounding the trial and implantation of spinal cord stimulation. And we have back again with us my favorite anesthesia pain doctor, Dr. Ramo Naidu, to answer these questions. So let's say the insurance company approves it. Now we're ready to go on to trial and maybe the implant. The spinal cord stimulator is an interesting thing because you put this lead up and it's kind of a try before you buy a situation where if it works, then great. If it doesn't, you don't have to have it in. So talk to our viewers about what that process is and how you actually get a trial and what patients have to go through. And I'll hold this model up for you as best as I can.
Great. So overall, the process is very similar to getting an epidural steroid injection. The only difference is rather than injecting a steroid, we're actually injecting this lead or wire. So the needle comes into the epidural space. Usually,
let me try to hold this needle.
Perfect. And then we're able to, through the needle, place the lead in and drive it up the epidural space. And we'll see how it does in this model here, but I'll push it through.
There it goes.
Perfect. And then we can watch using x-ray where it goes, and it's usually about T7 to T9 in the thoracic spine. So even if the pain is coming from the legs or low back, we are going to the thoracic spine because the spinal cord ends around L1 and L2. And if someone had arm pain or neck pain, we can actually put these in the cervical spine as well. So the needle comes out.
So this lead stays in, needle comes out.
Correct.
I'll try to hold this lead in for you.
Perfect.
Okay.
And then we just connect this to something called an external programmable generator, or an EPG. And
this is coming out of the skin at
out
this
of the
point.
skin.
So this is exiting the skin, and this is outside
of the skin. And then we tape this all down to try to make sure it doesn't move too much. And then that remains in place for usually about a week. Some people do less, some people do more. And then at the end, my assistant removes the tape, pulls out the wire.
So this just comes out, and
Yep.
really all you do is you just pull that
Pull it
wire
out.
out, and that's it. And that's in the office.
That's right. And we throw everything away. And then after that, you determine whether you want to move forward with the implant. And so criteria for success, as we mentioned, is at least a 50% reduction in pain, improvements in function, and reduction in medication use.
If during the trial time, even if it does work, you're like, this is kind of wild, I don't want this. No big deal. You just have a little stab incision in your back from that needle. And so there's really no downside to having the trial other than the risks of the trial itself.
That's correct.
It's completely reversible.
Completely reversible. The only restriction being don't submerge in water or get extremely wet. And look, if it doesn't work out for you, don't be afraid to say that. About 20 to 25% of the time, it doesn't work out. And hopefully your provider has other options for you.
So let's say you come in, it was a great, patient says, Dr. Naidu, this thing was like the greatest thing since sliced bread. First time I didn't have leg pain. How do we go about actually converting this to an implant?
Great. So usually about 2 weeks after we remove those wires, we want those needle poke holes to heal in so there's no greater risk of infection. Then we bring you back to the operating room, and we now do almost the same procedure, but we're going through 2 incisions.
So I'll hold this model back up
Perfect.
for you.
So one of those incisions is exactly where the needle was placed.
And I'll hold that once again.
And then we anchor them or suture these down to what's called a fascia, which is a tough layer of tissue. And then this is tunneled underneath the skin to a battery or what's called an implantable pulse generator, an IPG. And this is through a 4-centimeter incision and then sutured, closed, adhered. And so when it's all done, everything is under the skin. And after usually about 2 weeks, you're free to do any water activities you want.
And so your butt is kind of here, and so this is just kind of tucked underneath.
That is correct. And you can choose which side you want on, left versus right. Some providers or patients prefer to have it in the flank, for example, if they wear a tool belt for a living. So you have some options there. We just don't want this to be in a bony area.
Okay, and then that's the permanent implant, and then you're done.
Correct, and that's usually done under deeper sedation, also called monitored anesthetic care. If you have general anesthesia, then we do strongly recommend neuromonitoring to make sure that the providers can tell if there's any neurologic injury during the procedure.
I use neuromonitoring when I do spine surgery. This is another person in the room. They put little needles, like acupuncture needles in your arms and legs, so that while I'm doing surgery, we know that there's nothing going on with the cord or nerve. Same thing with this.
Exactly.
And this would be done, the permanent one, to be clear, would be done in an operating room.
That is correct.
where you're actually making, not poke hole incisions, but not giant incisions, 4 centimeter incisions, one here and one down there.
That's correct.
And you're suturing that,
Yes.
and you glue it closed.
That's correct.
Okay. So, if a spinal cord stimulator has been recommended to you, you may have heard about something called a paddle implant versus a percutaneous lead. So, there are surgeons that would recommend placing a paddle. So, instead of this lead going up, you place a paddle. Now, how a paddle is placed is, if this is the spine and this black portion is the lamina, a surgeon like myself would do what's called a laminectomy in the thoracic spine. We remove a little bit of this bone, and you have to do that to get this paddle. So no longer is it just a wire, it's a wide paddle that goes over the spinal cord and sits there. And I know there's lots of debates about which is better, the paddle versus the percutaneous lead. I'm not sure if it's a turf war between surgeons, between anesthesia pain doctors, etc. But talk me through the idea of when somebody might want a paddle versus a percutaneous lead. And most importantly, what our viewers are going to want to know is which one's better, a paddle or percutaneous lead?
Great question. So I will say historically, the thought was that paddle leads were better. And the reason for that, a few reasons. Number one, you're able to lie this flat closer to the spinal cord, so less energy is required. So that could lengthen the life of the battery charge cycle. And also because he has to open up the skin and suture directly onto bone, these things aren't going to move very much. And so yes, migration rates were historically worse with percutaneous leads, but in the last 10 years, we've had some retrospective data that show that basically the migration rates are similar between both styles. And so generally people are preferring percutaneous systems compared to paddle systems. With all that said, the outcomes are relatively similar, and I would just advise if your provider is extremely comfortable with one technique, let them do that, because the best paddle implanter is just as good as the best percutaneous implanter, so you just want to make sure they're in their comfort zone.
But at the end of the day, a paddle implant always requires a laminectomy done by a surgeon, which is making an open incision, removing some bone, and there is a chance of a dural tear, which is a tear in the covering of the nerve and cord. In our practice, we have a comprehensive spine-only practice. We have anesthesia pain docs, we have physiatrists, we have surgeons. We always try to do what I think is the least invasive thing for the patient. So, 9 times out of 10, if somebody needs a spinal cord stimulator, I'm usually going to have one of our anesthesia pain guys do it percutaneously, because it's just less invasive and the outcomes are very similar. There are times where patients had a prior laminectomy. We've removed some bone here, and so there's a bunch of scarring. You physically can't thread this lead up. So in that situation, we have no choice but to do a paddle. But I think 9 times out of 10, in our practice at least, you're placing percutaneous leads, and the patients actually do quite well.
That is correct. There's a place for paddle leads, and one other point is that they're a little bit more difficult to explant compared to the percutaneous systems, which can be removed relatively easily.
Right, I have to do another surgery to actually take that paddle off, make another open incision, it might be scarred down. So obviously for these paddle implants, surgeons, like myself, we're doing the laminectomy, putting the paddles on, but what about these percutaneous implants? What kind of doctors are doing these percutaneous implants? And most importantly for our viewers, if your family member had to have a percutaneous spinal cord stimulator placed, how are you going to evaluate the best doctor to do that?
Great question. So as you mentioned, for the paddle implant systems, it's orthopedic spine surgeons and neurosurgeons. For the percutaneous systems, it can be a wide variety of physicians, anesthesiologists like myself, physiatrists, neurologists, emergency medicine, radiologists, family practice even. And while we can debate who has a different or best residency type, what it really comes down to is experience, how much volume they've done. So you want to ask your physicians, how many times have you done this? How many implants have you done? How are your outcomes? And we're getting better transparent data out there, but really talking to your physician about this is really the most important thing you can do.
How many procedures would you want to see that person who's going to do that stimulate on your family member have done?
Yeah, great question. This is an arbitrary number, but at least 200 implants. And we just know with any procedure or surgery that the more you do, the better you are. You refine your technique. And no offense to the younger pain physicians out there, but generally it takes about 5 to 7 years out of fellowship before you become really proficient and highly skilled at doing these implants. And so you do want to talk to your physicians about that, not to say that they won't become magnificent and great physicians, but generally that's what we've seen.
We did a episode on how do you choose a spine surgeon on the Spine Guy, and that really is in alignment with what you just said, which is 5 to 7 years out, having done at least a couple of hundred cases. So I think that aligns. So I know from going to these different spine meetings that there are many different types of spinal cord stimulator manufacturers. I think there's 7 major types. They all have subtle differences in technology, waveforms, MRI compatibility, bells and whistles. So help our viewers understand what the differences are between all of these different companies.
Great question. So if one company was far better than another, we'd all be using that one company. So the marketplace is really healthy right now. As you mentioned, there are 7 companies as of 2025, 2026. And they all work very well. So, as a healthcare consumer, you want to choose the company that your provider is most comfortable with. For me personally, I work with all the systems. So if someone happened to like one system versus another, I would be happy to do that for them. There are some subtle differences. And one key point, as you mentioned, is MRI conditionality. So just about 10 years ago, before that, none of these systems were compatible.
Meaning you couldn't get an MRI.
You couldn't get an MRI.
Because an MRI is a magnet, this is a metal lead, so there's obviously artifact or potential migration of the lead.
That's correct. And so if you develop cancer or multiple sclerosis, that became an issue. We had to take these devices out. So now we have MRI conditional systems, and basically every system is MRI conditional, but those conditions vary. And so as of right now, Medtronic and Biotronic have the best conditions to get an MRI. So if you need to get MRIs in your future, those are probably the 2 companies you want to steer towards. Waveforms has been a hot topic over the last 10 years. Nevro launched high-frequency stimulation, which was the first time we stopped feeling the stimulation. So before that, you felt the stimulation, the tingling, the burning. But now all the systems have shifted to their own waveform or their own stimulation paradigm. You don't feel it at all. And with all of those, we've proven that they're very effective, but there hasn't been a head-to-head to really say one is better than the other than, again, they all work. The latest innovation in spinal cord stimulation has been remote monitoring, and that's the ability for someone from a remote location to be able to identify and understand any diagnostic issues and reprogram you anywhere in the world as long as you're in a cellular phone network or a Wi-Fi network. And that's really cool. And that came to the cardiac world in 1987, and the company that did that was called Biotronic, and now they're doing the same thing for spinal cord stimulation. I think every spinal cord stimulator will have this capability in 5 to 10 years.
So you put a stimulator in somebody and they're on vacation in Europe, and there's some issue with their stimulator, you can figure it out from here in California.
That's correct.
Okay.
And fix it.
So Dr. Naidu is highly respected in the field of spinal cord stimulation, and as such, I think every company almost has you as their consultant. And so I always say that you're only unconflicted if you consult for nobody or if you consult for everybody. So you consult for everybody, so I would consider you unconflicted. If this is your family member or in your current practice, what would you say you're putting in 90% of the time in terms of type of spinal cord stimulator?
So as of 2025, 2026, it's currently the Biotronic Prospera system. And the reason for that is for the remote therapeutic monitoring and diagnostics. I think that's a huge thing for patients. It gives them security. It gives them belief in the therapy because if issues arise, we can identify them quickly and fix them quickly. And that is missing in every other spinal cord system right now. But as I said, I think they will catch up.
Do you think that's all going to equalize?
I think so.
Okay. And let's talk quickly about closed loop systems. I've heard some companies talk about a closed loop system. What are the advantages of that, and what is closed loop?
Yeah, there are 2 companies right now that have closed loop systems. It's Saluda and Medtronic. And the idea here is to listen to a signal from the spinal cord to adjust or adapt the stimulation. So an analogy would be cruise control in your car. You set it at a very specific mile per hour, and whether you go uphill or downhill, you're trying to keep that car at the same speed. That's what this is trying to do with stimulation. Now, with that said, really cool concept, love it. It just hasn't proven to be better than anything else out there when it comes to waveforms. So until we see data that shows that it is actually better, right now closed loop systems are cool, but they're really not more effective than any other thing on the market.
And this is because a spinal cord floats in that spinal fluid back and forth. So if you're coughing or something like that, or you're moving, that cord might float. but that electrode is sitting over it, so this kind of adjusts in real time for that distance.
That is correct. And that was an issue with our older systems that used what was called tonic or traditional stimulation, but the whole market has shifted in the last 10 years to moving away from that. So that's really not an issue anymore.
I've also heard about something called DRG stimulation or dorsal root ganglion stimulation. So as a reminder for our audience, if this is a spine and this yellow thing is the nerve, this bulbous thing in the nerve is called the DRG. It's where all the cell bodies live. And I do know there's some procedures where you can actually, instead of putting this up in the spine, you can come across and try to target one of the nerves specifically. So tell me, is DRG and SCS the same thing?
They're not quite the same thing. They're both neurostimulators, but they have different targets. As you alluded to, the DRG is going after the dorsal root ganglion.
One nerve.
For one nerve, but you can put up to 4 leads, so
Okay.
you could theoretically do 4 nerves. And the spinal cord stimulator is doing the dorsal columns or the dorsal horns of the spinal cord. Now, the indications for use, while there's a small overlap in where we might use both systems or one versus the other, in general, dorsal root ganglion stimulation is used for focal neuropathic pain. So, for example, complex regional pain syndrome of the foot or the hand, or a post-surgical pain. For example, some patients have chronic pain after a total knee replacement. Dorsal root ganglion stimulation would be ideal for that, whereas spinal cord stimulation would not be.
And are all DRG stimulators the same? And does every company that makes an SCS also have a DRG stimulator?
No, Abbott is the only company that has an FDA-approved dorsal root ganglion stimulator. And I'll point out that the outcomes with dorsal root ganglion stimulation are amazing. So you can have a 90% responder rate with DRG stimulation. And as we talked about with spinal cord stimulation, depending on when the study was done and which company, it's anywhere from 50 to 80% success rate.
Thanks for watching. I think this is going to be the best video on YouTube about spinal cord stimulation, and it will answer any question patients have before they get a trial and implant of a spinal cord stimulator. I want to thank our esteemed guest, Dr. Naidu, and stay tuned for yet another video that's going to talk about questions patients may have after they get the implant. Don't forget to click like and subscribe.